Assalamu alaikum, it's me Dr. Naseem Shirzad, and today I am going to discuss with you all renal cell carcinoma with IVC thrombus. Around 5 to 10% patient of RCC present with IVC thrombus, and on clinical examination, these patients with renal cell carcinoma having IVC thrombus include lower limb edema, caput medulla, isolated right-sided varicocele, non-reducible left varicocele, proteinuria, and hepatitis grade 4 involving the right atrium mass and a non-functioning ipsilateral kidney. That's why it is important to examine the patient of RCC, examine their lower limb, examine their scrotum for any varicocele. So these are the important findings of IVC thrombus in a patient with RCC. Now there are various level of IVC thrombus in which there is a grade 1 which is just limited to the renal vein. This is the grade 1 which is limited to the only to the renal vein, and then there is a grade 1. This was grade 0 which was limited up to the renal vein, and then there is a grade 1 which means that the tumor is extending to renal vein, above renal vein ostium, less than 2 centimeter above the renal orifice. So grade 1 is extended of the tumor thrombus less than 2 centimeter from the ostium, renal vein ostium. And now the level 2, that is the tumor that is extended more than 2 centimeter, but more than 2 centimeter of the renal orifice, but that should be below the hepatic vein. And the level 3, which is in which the tumor is extending above the hepatic vein, this is a level 3 which is extending above the hepatic vein and but below the diaphragm. In some cases they have divided this level 3 into 4 further grading, in which they have divided 3A, 3B, 3C and 4D, and sometimes they are asking it in exam. Now the 3A means intrahepatic, 3B means hepatic, 3C means suprahepatic, and 3D means suprahepatic. So 3A means intrahepatic, means a thrombus that is extending into the retrohepatic IVC, but that is below the level of the hepatic vein. When it is below the hepatic vein, that is called intrahepatic. 3B means hepatic, a thrombus which is extending into the retrohepatic IVC, but that is reaching the ostia, the renal vein ostium. It can reach the ostium of the major hepatic vein. This is the hepatic vein, so it reaching into the ostium of the hepatic vein, and it may extend into them and causing Budd-Chiari syndrome. Now 3C, that is called suprahepatic, and it means that the suprahepatic, it means that the thrombus is extending into the retrohepatic IVC above the major hepatic vein, and it extending from this renal vein above the hepatic vein but at below the diaphragm. And 3D means that a thrombus is extending into the supradiaphragmatic part, it extending into the supradiaphragmatic part, but below the but it is not involving actually the right atrium. And it's saying that the group 4, which we are saying that is above the diaphragm, and they classify it group 4 into the one which is involving the right atrium. So for simplicity, grade 1 is limited, 0 limited to the renal vein, grade 2 less than 2 centimeter above the renal vein ostium, grade 2 means more than 2 centimeter above the renal ostium but at below the hepatic vein, that is grade 2, and grade 3 means that the tumor extending above this hepatic vein but below the diaphragm, this one, and grade 4 means that the tumor thrombus extending above the diaphragm. So this is the diaphragm, and when it is above, it is grade 4. So there is a simple Mayo classification. Now it's important, is the tumor involving the right or left side? So per 0 and 2 For 0, we can go for radical nephrectomy with a patch of the IVC, and for grade 1, we can go for partial clamping and milking of the IVC. But regarding grade 2, it is important to have a concept of sequential clamping. And the incision which are we giving for this surgery is the chevron incision, because we need a more exposure. So we need bilateral subcostal transperitoneal or chevron incision, and for this it is important to have understanding of the sequential clamping. But again, when the tumor is in the right side, that is called a good tumor, but if it is on the left side, it is called a bad tumor, because on right side we don't have any collaterals, while on left side we are having collateral. So the concept of sequential clamping, number first, is to apply the infrahepatic, which is below the hepatic vein. Then we will, if we make it clockwise, like it is a 12 o'clock, it is a 6 o'clock, and it is a 3 o'clock, and it is 9 o'clock. So number first clamp is infrahepatic clamp. That should be applied first, because when we apply the first clamp here, so there will be no outflow into the heart, so it will decongest all the system. The second clamp, if the tumor is on the left side, we will apply the second clamp on the right, on the left renal vein, and on the third clamp we will apply that above the renal vein, means in the caudal position. So first clamp here, second on the contralateral kidney renal vein, and the third is the involving the suprarenal vein. So these three clamp, and the removal is the same. First we will remove the below one, because when we remove this, there will be gush of blood, and it will tell us that there is no leak, and it will tell us about the patency of our anastomosis. If there is any bleeding, we will again apply the Sikatensky clamp again here. The second, we will remove the renal vein, and the third will be the suprarenal clamp. This is the removal sequential. Now if the tumor is on the left side, so on the right side we have already discussed. Now coming to the left side, because we have no collateral on the right side to apply them. So if the tumor is on the left side, the IVC is carefully dissected to the bifurcation, ligating the right gonadal vein on its interior surface. We will clamp the gonadal vein, and then we will again apply the sequential clamping to the ipsilateral left renal artery is ligated. We will first ligate the left renal artery. Then we will come in to apply the infrarenal IVC, and then the suprarenal IVC is clamped. The contralateral renal vein is clamped along with renal artery, and then the suprarenal IVC. So number first clamp, the ipsilateral renal artery ligated. The second, the infrarenal IVC ligated. The third is the contralateral renal vein plus artery. We will be clamping the artery plus vein in same setting, as there is no collateral in this. If we just ligate the renal vein, there will be engorgement of the kidney. So our intention to perform this whole process of thrombus evacuation just in that ischemia time. So for left side tumor, it's a difficult surgery, and we need the clamping of the renal vein plus the renal artery in one setting. So now to make it very simplified, and if the tumor is involving the canal wall invasion, like if the tumor is in the wall of the IVC, if it is occluding less than 50% of the IVC lumen, we can just excise that tumor. But if it is more than 50%, or we need to ligate the suprarenal vena cava. So in this sense, we are saying that the right sided tumor is a better tumor, because if we want to ligate the suprarenal vena cava, be having alternate drainage on the left side. Now if the tumor is on the right side and we want to go for tumor thrombectomy, So the suprarenal vena cava is resected, and we will ligate the left renal vein distal to its tributary, which will provide the venous drainage from the left kidney. So if the tumor on right side, we will ligate the suprarenal vena cava, and we will also ligate the left renal vein distal to the tributary. So the left side kidney having three collateral drainage, like it can drain it from gonadal vein, which we also call testicular vein, the adrenal vein, and the inferior phrenic vein. So these three can still giving drainage to this kidney. But the problem is with the left side. If the tumor is on the left side, and we are going to perform the left nephrectomy, radical nephrectomy with tumor thrombus, and we want to ligate the suprarenal vena cava. So on the right side, we are actually having no alternative drainage for the right kidney. So in this, we have two options: either to go for autotransplantation, or make to place a great saphenous vein grout between the right kidney renal vein and connect them to the splenic vein or portal vein or the inferior mesenteric vein. Otherwise, we will be having no option. Same is the scenario if we having a tumor on the right side, we can ligate the renal vein for some time. But if you are having tumor on the left side, we will be having no chance to ligate the renal vein alone, because there is no collateral, and the blood which is coming through right renal artery, that will be engorge the kidney. That's why on left sided tumor, we ligating the contralateral renal vein plus artery, and we will be performing our thrombectomy in this time of warm ischemia time. So it is important both for warm ischemia time, that is the suprarenal vena cava ligation, and that is the contralateral site renal vein and artery ligation in case if the tumor is on the left side. As I have shown in this diagram, that we can ligate the left sided vein, renal vein, but not on the right side. So this concept is important.